Welcome to Drugs for COPD. I hope you're having a great day.
This information is brand new this year from the Global Initiative for Chronic Obstructive Lung Disease, or GOLD. The GOLD report is updated annually in January.
GOLD's definition of COPD was changed in its 2017 report. COPD is a common, preventable, and treatable disease that is characterized by persistent respiratory symptoms and airflow limitations that are due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. The report emphasizes that COPD may be punctuated by periods of acute worsening of respiratory symptoms called exacerbations. Note that the terms emphysema and chronic bronchitis have been removed in favor of a more comprehensive description of the pathophysiology of COPD. The chronic airflow limitation that characterizes COPD is caused by a mixture of small airway disease, obstructive bronchiolitis, and parenchymal destruction, or the emphysematous part of it, the relative contributions of which vary from person to person. Chronic inflammation causes structural changes, small airway narrowing, and destruction of lung parenchyma. A loss of small airways may contribute to airflow limitation and mucociliary dysfunction, which is a characteristic feature of the disease. The primary criterion for diagnosis is unchanged. The FEV1 should be less than 0.70% or 70%. Spirometry remains important to confirm the diagnosis in those with classic symptoms of COPD, including dyspnea, chronic cough, and sputum production.
This is the first of two scales to quantify dyspnea. The scales are important, as you will see, in the determination into which treatment group the patient falls. The modified dyspnea scale has been developed by the Medical Research Council, and that's what MRC stands for. And the MRC dyspnea scale is a questionnaire that consists of 5 statements about perceived breathlessness. COPD impacts patients well beyond dyspnea. For this reason, a comprehensive assessment of symptoms is recommended. The COPD Assessment Test, or CAT, is included in the ABCD classification of severity of COPD. A copy is available under Blackboard under your required readings. Low symptom severity is considered as a CAT score less than or equal to 9, and high symptom severity is considered as a CAT greater than or equal to 10.
This is the ABCD assessment tool. The patient is first diagnosed via spirometry and then graded 1 to 4, and that's it with that part of it. The new system uses symptom severity and exacerbation risk to classify COPD into groupings, and these groupings then determine the treatment. So group A, they have low symptom severity and low exacerbation risk. Group B has high symptom severity and low exacerbation risk. Group C has low symptom severity and high exacerbation risk, and Group D has high symptom severity and high exacerbation risk. Notice that the risk, the history, is divided into the low would be 0 or 1 exacerbations and no hospitalizations, and high would be greater than 2 exacerbations or at least 1 hospitalization. Okay, consider 2 patients. Both patients have an FEV1 that is less than 30% of predicted. Remember, 70% of predicted is diagnostic of COPD. So these patients are pretty bad, which puts them in a grade 4 category. And both had CAT scores of 18. But one patient had no exacerbations in the past year, and the other one had 3 exacerbations in the past year. With the new proposed scheme, the patient with 3 exacerbations would be labeled Group D. So gold grade 4, Group D. The other patient who has no exacerbations would be classified as gold grade 4, Group B.
Here is MP, who's a 67-year-old man with chronic cough and sputum production. He has an FEV1 FVC of 68%, which is below the 0.7%, or 0.7 or 70%, and an FEV1 of 65% of predicted. His CAT score is 15. He has never been hospitalized nor been diagnosed as having an exacerbation. MP can be classified into which of the following groups? So he has a CAT greater than 10 and no exacerbation, which makes him a Group B, which on this is answer C.
We are going to focus the majority of our time on treatment of stable COPD. Pharmacologic therapies can reduce symptoms and the risk and severity of exacerbations, as well as improved health status and exercise tolerance. Most of the drugs are inhaled. Inhaled bronchodilators in COPD are central to symptom management and commonly given on a regular basis to prevent or reduce symptoms.
Here are the initial treatments for the ABCD classification. We will talk about each of these.
All COPD patients should have a rescue inhaler, usually albuterol. And remember, ProAir HFA is now generic. Regular and PRN use of a short-acting beta agonist or a short-acting muscarinic antagonist improves patients' short-term FEV1 and their symptoms. Combinations of the SABA and SAMAs are superior compared to either medication alone in improving short-term FEV1 and symptoms. Combining agents from different classes, such as albuterol plus tiotropium, for more benefit with better tolerability. For inhaler treatment for Group A patients. So these are the patients with a CAT score of less than 10 and with no exacerbations and no hospitalizations. So they should have a short or long-acting bronchodilator. So usually we start with a short-acting bronchodilator as needed. And then if their symptoms persist, we can add a long-acting bronchodilator. Tiotropium is kind of the one we go to for long-term or long-acting bronchodilators. It improves lung function and reduces exacerbations, but doesn't reduce hospitalizations.
Okay, initial therapy for Group B patients, and these are the patients with the CAT score that's greater than or equal to 10 and who only has one or no exacerbations in the last year, and no COPD related hospitalizations either. So, initial therapy should consist of a long acting bronchodilator, and their superior long acting bronchodilators, or LABAs, are superior to short acting bronchodilators taken as needed and are therefore recommended. There's no evidence to recommend one class of long-acting bronchodilators over another for initial relief of symptoms in this group. I tend to go to the LAMAs, the long-acting muscarinic agents. LABAs and LAMAs significantly improve lung function, dyspnea, health status, and reduce exacerbation rates. Now, two long-acting bronchodilators can be used for severe breathlessness, and that combination increases the FEV1 and reduces symptoms compared to monotherapy. Okay, looking at MP again, who has the CAT of 15 and no exacerbations or hospitalizations. He is a Group B. So how would you treat him? So he definitely needs a rescue inhaler, probably albuterol or ProAir HFA, which is now generic. He also needs to be on at least one long-acting bronchodilator. So it could be like a LABA like salmeterol or a LAMA like tiotropium. Okay, here's the initial inhaler treatment for Group C. And Group C patients have a CAT score of less than 10 with greater than or equal to 2 exacerbations or 1 or more COPD related hospitalization per year. So initial therapy should consist of a single long-acting bronchodilator. And in this group, LAMAs are preferred over LABAs if only one long-acting bronchodilator is used. LAMAs are superior in preventing exacerbations in this group. Okay, this is the initial inhaler treatment for Group D, which are patients with CAT scores greater than or equal to 10, or 2 or more exacerbations, or 1 or more COPD related hospitalization per year. So in general, therapy can be started on a LAMA, our long-acting muscarinic antagonist, as it has effects on both perceived breathlessness and exacerbations. So for patients with more severe symptoms, and that's a CAT score greater than or equal to 20, especially driven by greater dyspnea and or exercise limitation, LABA-LAMA combinations may be chosen as the initial treatment based on studies with patient-reported outcomes as the primary endpoint, where LABA-LAMA combinations showed superior results compared to single substances. Now, something a little different, the GOLD 2021 guidelines suggest considering the blood eosinophil counts to help determine if starting an inhaled steroid may be beneficial. The idea is eosinophils can help pinpoint COPD patients who have inflammation and may be more likely to benefit from inhaled steroids. COPD patients with a history of asthma may also benefit. Evidence suggests inhaled steroids may decrease COPD exacerbations if the eosinophil counts are above 300 cells per milliliter, or about 4% of the total white blood cell count. But there may not be benefit below 100 cells per milliliter, or less than 2%. So be aware, these are soft cutoffs. Plus, steroids drop eosinophils, so counts may be low in patients who recently used an inhaled or systemic steroid and won't help decide about stopping an inhaled steroid. So continue to save inhaled steroids for COPD patients with severe symptoms or exacerbations. If you're on the fence about starting one, consider the eosinophil count to help decide. But remember, first, you always have to optimize bronchodilators and reinforce proper inhaler use. Now, again, the inhaled corticosteroids must be combined with a LABA and may cause pneumonia in COPD patients, especially those with severe COPD. And note that these are inhaled corticosteroids, not oral/systemic ones. So discontinue the inhaled corticosteroid if improvement is not seen after you add it due to the increase of adverse effects with use and a lack of harm seen with discontinuation. If response to the initial treatment is appropriate, maintain it. If not, consider the predominant treatable trait to target, so either dyspnea or exacerbations. Use the exacerbation pathway if both dyspnea and exacerbations need to be targeted. Okay, so this is the latest on the 2021 guidelines. So you place the patient in a box corresponding to current treatment and follow the indications. You assess their response and you adjust and review. These recommendations do not depend on the ABCD assessment at diagnosis. If the patient is experiencing dyspnea on follow-up, at all stages, dyspnea due to other causes that might not be COPD related should be investigated and treated appropriately. Inhaler technique and adherence should be considered as causes of inadequate treatment response. For patients with persistent breathlessness or exercise limitation, on a long-acting bronchodilator monotherapy, meaning just one medication, the use of 2 bronchodilators is recommended. If the addition of a second long-acting bronchodilator does not improve symptoms, the treatment could be stepped down again to monotherapy. You could also consider switching the inhaler device, the way it's delivered, or medication in those devices. For patients with persistent breathlessness or exercise limitation on a LABA ICS treatment, LAMA can be added to escalate to triple therapy. Alternatively, switching from a LABA ICS to LABA LAMA should be considered if the original indication of the inhaled corticosteroid was inappropriate. For instance, an ICS was used to treat symptoms in the absence of a history of exacerbation, or there has been a lack of response to the inhaled corticosteroid treatment, or if the inhaled corticosteroid side effects warrant discontinuation. Okay, if the patient has exacerbations on follow-up, as previously stated, check the inhaler technique and adherence to the treatment regimen. The patient should be on a LABA or LAMA at a minimum. You could change them to a LABA LAMA or a LABA ICS with exacerbations. Again, the inhaled corticosteroid focuses on the eosinophil counts. So a LABA ICS, the inhaled corticosteroids, benefits those with 1 exacerbation per year and eosinophils greater than or equal to 300 per milliliter, or about 4% of the total count, or greater than and equal to 2 exacerbations per year, or 1 with hospitalization and eosinophils greater than or equal to 100 milliliters, or about 2% of the total count. Now, if the exacerbations on the LABA/LAMA continue, consider changing to triple therapy, the LABA/LAMA ICS, if the eosinophil count's greater than or equal to 100. Adding roflumilast, which is Daliresp, and by the way, that will be becoming generic this year in 2021, or azithromycin if the eosinophils are less than 100 per milliliter or less than 2%. If exacerbations on a LAMA ICS continue, then you can change to triple therapy. And if the exacerbations on triple therapy continue, you can add the roflumilast. And we're going to be talking about that because it's a PDE4 inhibitor, and I think it's on upcoming slide. Adding azithromycin and stopping the inhaled corticosteroid if the side effects or demonstrates lack of efficacy. But again, if the eosinophil count is high, you have to watch closely for relapse of exacerbations if you withdraw the inhaled corticosteroid.
Long-term therapy with oral corticosteroids is not recommended. In patients who have exacerbations despite treatment, the addition of a phosphodiesterase type 4 inhibitor can be considered. The specific PDE4 recommended for COPD is roflumilast. Antibiotics such as azithromycin may be given long-term to reduce exacerbations, but bacterial resistance is always a concern, and I've not actually seen this happen very often.
All right, here's another case study. This is a 65-year-old woman with emphysema, so that automatically puts her out of the A, B, C, D categories. So you need to look at the slide that has dyspnea and exacerbations on it on follow-up. So her last exacerbation was 6 months ago. So she really isn't on the exacerbation category. She's on the dyspnea category. Her current COPD pharmacotherapy includes tiotropium, 18 milligrams once daily, an albuterol meter dose inhaler as needed, and formoterol, 12 milligrams every 12 hours. She's adherent and uses them correctly, but she's had to use her albuterol more times over the last 3 months and has increased breathlessness. So she denies any changes in her sputum, which basically means that this was a gradual onset, no changes in sputum, so this is not an exacerbation. Her post-bronchodilator FEV1 today is 42%. CAT score has increased from 10 to 12, which is the following. So let's look at these choices. Choice 1 is the roflumilast, which is Daliresp, and it's a PDE4 inhibitor. Now, it wouldn't be a bad choice if she was on the exacerbation track, so it's not a good one for her. Choice 2 is oral prednisone, and again, she's not having an exacerbation, but a gradual worsening of symptoms, so this isn't needed. Choice 3 would be a LABA with an ICS, and this choice seems reasonable if she was having exacerbations, so again, she's not. Choice 4. This one, the med is a good choice, but not the strength for COPD. COPD treatments approved for only 250 and 50, and she's not on the exacerbation track. And choice 5. This option is the best, as it changes the molecules in her medication and combines them into one inhaler. It's also a different type of inhaler because it's a DPI, a dry powder inhaler for both. Tiotropium was a flexhaler, which is a soft mist inhaler, and the formoterol, I believe, was a dry powder inhaler. So we're going from two different types to just one type. Now, this question is harder than what you'd get on an exam, mostly because I don't make you memorize dosages. In a question like this on the exam, I would not give you option D. We've been talking about treatment determination based on the frequency of exacerbations, but we haven't really defined it. So, an exacerbation is an acute event characterized by a worsening of the patient's respiratory symptoms that's beyond normal day-to-day variations and leads to a change in medication. It's an acute change in one or more of these three items. The cough increases in frequency and severity. Sputum production increases in volume or changes character. And dyspnea increases. These are what we see in primary care during an exacerbation. A patient will come in with these symptoms. So, how to manage an acute exacerbation? So, these three classes are most commonly used. So, bronchodilators, short-acting inhaled beta-2 agonists with or without short-acting anticholinergics are recommended as initial bronchodilators to treat an acute exacerbation. Systemic corticosteroids can improve lung function and increase the FEV1, oxygenation, and shorten the recovery time. The duration of the therapy should not be more than 5 to 7 days. And then antibiotics, when indicated, can shorten recovery time, reduce the risk of early relapse and treatment failure. Duration of therapy should be for no more than 5 to 7 days also.
These are summary of bronchodilator use in COPD treatment, and this is from the GOLD guidelines. Inhaled bronchodilators in COPD are central to symptom management and commonly given on a regular basis to prevent or reduce symptoms. Regular and as-needed use of short-acting beta agonists or short-acting muscarinic agonists improves FEV1 and symptoms. Combinations of short-acting beta agonists and short-acting muscarinic agonists are superior compared to either medication alone in improving FEV1 and symptoms. Long-acting beta agonists and long-acting muscarinic agonists significantly improve lung function, dyspnea, health status, and reduce exacerbation rates. Long-acting muscarinic agonists, have a greater effect on exacerbation reduction compared with long-acting beta agonists and decreased hospitalizations. Combination treatment with a LABA and LAMA increase FEV1 and reduces symptoms compared to monotherapy. Combination treatment with LABA and LAMA reduces exacerbations compared to monotherapy. Tiotropium improves the effectiveness of pulmonary rehabilitation in increasing exercise performance. Theophylline exerts a small bronchodilator effect in stable COPD, and that is associated with modest symptomatic benefits. These are the summary of anti-inflammatory use in COPD from the GOLD guidelines. An inhaled corticosteroid combined with a LABA is more effective than the individual components in improving lung function and health status and reducing exacerbations in patients with exacerbations and moderate to very severe COPD. Regular treatment with an inhaled corticosteroid increases the risk of pneumonia, especially in those with severe disease. Triple inhaled therapy of an inhaled corticosteroid, a LABA, and a LAMA improved lung function, symptoms, and health status, and reduces exacerbations compared to an ICS combined with a LABA combined with a LAMA, or LAMA monotherapy. Long-term use of oral glucocorticoids has numerous side effects. For PDE4 inhibitors, patients with chronic bronchitis, severe to very severe COPD, and a history of exacerbations, a PDE4 inhibitor improves lung function and reduces moderate and severe exacerbations. A PDE4 inhibitor improves lung function and decreases exacerbations in patients who are on a fixed dose LABA inhaled corticosteroid combination. Antibiotics. Long-term azithromycin and erythromycin therapy reduces exacerbations over 1 year. Treatment with azithromycin is associated with an increased incidence of bacterial resistance and hearing test impairments. Okay, thank you for your time and attention. I hope that you've learned something about COPD and its treatment.